Hey everyone, welcome to another week of Antidote Stories in Medicine. This is Christine. I am so sorry there was not an episode last week, but sometimes when you work with sick people, you also get sick. So because there was no episode last week and because I was not able to release this update about the giveaway for Dr. Howard's book, Cognitive Errors and Diagnostic Mistakes, I'm going to push the giveaway back a little bit. So now you can still enter until this Saturday, which is April 13th at midnight Eastern Standard Time. So my clarification was that, yes, you can enter from anywhere in the world. I will mail the book to you. That is no problem. To enter, all you have to do is take a screenshot of how you shared the podcast, and that counts from if you shared it on March 22nd until now. And any sharing on Facebook, any sharing on Reddit, on Instagram, Twitter, wherever, just take a screenshot of it so that I can see that you did it. That way I can give you credit and then enter you in for the raffle, because a lot of times I don't get notifications that you are sharing the podcast. So this will make it much easier. I will enter you. And that was the big update that I wanted to give you last week. And so that's why I'm extending the entries. So make sure you email me at antidotespodcast@gmail.com or send me a DM on whatever social media platform you want to use. Twitter, Antidotes Pod, Instagram, Antidotes Podcast, or obviously on Facebook, Antidote Stories in Medicine Podcast. And I will make sure you are entered. It's one entry for every review, one entry for every share. So you can enter multiple times, and then I will do the raffle over the weekend. And I will announce it for the podcast that following week, which will be April 15th or April 16th. So tax day for all of us Americans. And then hopefully you will pay your taxes and get a nice little surprise of a signed copy of Dr. Howard's book. So that is the little clarification. So now there's a little bit more of a time window to keep sharing. So I've already had some awesome reviews from Norway and Great Britain. It's so cool to have people listening from all around the world. And please, please, please keep sharing. And speaking of Great Britain, we are now going to be talking about a little bit of a different area of medicine, veterinary medicine. And this week's guest is from the UK. So welcome, Naomi. It's so great to have you.
Hi, Christine. How are you?
I'm good. How are you?
I'm great. I'm so thrilled to be here. Love talking about veterinary medicine on other people's podcasts. So I am excited to talk about this with you. I love talking about comparative medicine as well. So it's awesome.
I posted something on Instagram and you were like, oh, I wonder what old-timey veterinary medicine would look like. And I was like, oh, that would be just fascinating to compare them. I think just comparing veterinary medicine to human medicine is just interesting in general. But yeah, so you're an equine vet, correct?
I am, yes. So I've been practicing for about 12 years now, and for about 10 of those, I've now become an equine specialist. So I actually specialize in racehorses and competition horses, and my area of kind of normal day-to-day work is to do with orthopedics and lameness. So I spend a lot of time watching horses trot up and down for me. And it's basically, obviously the kind of puzzle with veterinary medicine is that they can't tell you where it hurts. So we then spend a lot of time doing diagnostics about what the problem is and how we can improve it in order to create the best performance for equine athletes, really. So that is how I spend my job.
So I grew up riding horses. My mom had multiple horses all the time, and she was a dressage rider, which if anyone is not, I mean, she wasn't very good at it, but if anyone does not know anything about horses, dressage riding is like kind of a ballet type of riding. It's like watching paint dry if you're not into horseback riding, but it's very hard. And there was a lot of time with the vet being around going, okay, trot her up and down, see where we're going. You know, is she lame? Is she not lame? She had this Trakehner mare, and then she had some Danish warm bloods for years and years, but they're gorgeous. I love riding. I miss it so much. It's just so expensive.
I know. That's the problem. That is definitely the problem. I haven't actually sat on a horse for about maybe like 4 or 5 years, I suppose. Now I'm much more likely to be found on a bike or a surfboard because it's a bit cheaper.
They don't get lame as easily.
No, you only get lame yourself. But no, it's a great sport. And personally, I am one of these people that does not have a lot of patience. Dressage is, I'm more of an adrenaline type of rider. So anything that involves going fast and generally quite out of control is usually more my bag.
Yeah.
But yeah, I'm a very admiring of the people that do dressage because it requires a lot of patience and control and skill and balance, which, you know, is very difficult to acquire and looks incredibly impressive when you do it well.
Yeah, I was more of the jumper cross-country person and, you know, racing across fields. And my mother was like, no, you need to sit there and have balance and isometric, you know, activity on the horse.
Yeah.
And people are like, this is so boring. But it's really so much fun. So before we were recording, I was asking you, how should I address you? Because here in the United States, veterinarians are doctors. They're doctors of veterinary medicine. And we would always say, you know, Dr. Mellor was your last name. And you said in the UK, that's not how you are addressed. So what is the training like for veterinarians? What's up with that?
So basically, we are a little bit different to the US in the sense of we don't do veterinary medicine as a postgraduate degree. So we do veterinary as an undergraduate. So I went straight from school at 18 to university to study veterinary medicine, and we take a 5-year college degree. And then at the end of that 5 years, that's it, you're done.
Okay.
So we don't have a doctorate automatically kind of enrolled in our degree education. We are allowed to take what they call a courtesy title of doctor, so the same as dentists in this country. And some people do, some people don't. So our kind of registration through the Royal College of Veterinary Surgeons, you will be addressed as doctor sometimes. But I think just because that wasn't the case when I graduated. I'd always been a miss, and then when I got married, a Ms. And so I have just kind of kept that, really. I think also my dad has a PhD, and he always used to tell me that unless you're an actual medical doctor or you've got a PhD, you're a bit of a fake doctor otherwise in this country. so I've kind of always had that in the back of my mind. And so that's why. And most people... I love it in the States, everyone's quite formal with their vet, but over here, most people would just call me Naomi. Like, everyone's really casual. Nobody would kind of refer to you as Dr. whoever, which when I worked in Australia, that was the normality there as well. And I found it really, really funny, actually, to begin with, because I'd never been addressed by anything other than my first name. And people would be like, oh, I'd like an appointment with Dr. Mellor. And I was like, okay, you can just call me Naomi. It's fine. I really don't mind. And yeah, so it's just something we've got used to. We're a little more casual, I think. So we would just, call each other just by our first names as usual. So.
Well, I think that's especially good when you're spending a lot of time out in a barn and a little bit of a dirtier profession. And, it's a very casual profession, even though there's a lot of knowledge behind it.
Yeah. I mean, like I wear jeans to work. I'm not a kind of, I try and dress a bit more smartly. I work at the racetracks as well. So I dress much more smartly when I'm at the races. And, there are certain occasions. This year, I'm lucky that I'm going to work at Royal Ascot, which is a really big, huge occasion in this country. And then you have to dress for like the royal enclosure with a dress and a hat and like high heels and everything. So it's kind of, it's just a bit horses for courses. But when I'm on my sort of daily rounds getting dirty, I'm definitely in my jeans and boots. So
I think a horse would take quite a big advantage of a white coat if you were to wear one around them.
They would freak out. I think they don't really like it if you're wearing anything too bright. And actually, I don't think it's a great coincidence. Like, people would wear a lot of kind of navy or green or black or whatever. I would just tend to wear t-shirt and jeans or whatever, just it's nice and easy. So it's all good.
Especially racehorses, because they're young and usually stallions, right? They're a little bit more finicky and flighty.
Yeah, I love the babies. I've done a lot of breeding work and reproductive work over the years, and I actually love the young horses and young animals. So the same as in the States, over here they race at 2, 3, and 4, and that they're still quite babyish when they first come into the racing stables, and I really like their personalities at that stage. I think it's a bit like kind of teenage children that are a bit sassy, but
yes,
they haven't been sort of blemished by life yet. They're sort of quirky and a bit inquisitive, and they're often just really fun at that age. So I really enjoy them then. And I think lots of people tell me that they're nervous of horses because they're really big animals. And I think if you haven't spent time with them before and you don't really know what you're doing, they can be quite intimidating. But I guess I've been around them a long time and you pick up the cues. And the one thing I really like about horses, and I always say to people about overdoing dog and cat work, is they tend to give you plenty of warning before you have a problem. Whereas me, I am not a cat person. I would really freely say that to anybody. I love dogs. I am not a cat person. And I find the kind of art of surprise attack to be quite tricky with cats, particularly when they're in your consulting room. So I much prefer with the horses, they tend to give you really good warning before they get too pissed off with you. So
I feel like horses don't really want to mess with you. They only do it because they're afraid of something, as opposed to cats. Sometimes they have a little bit of an agenda. And certainly I have this little tiny fur ball of a cat that beats up my 100-pound lab all the time. And he's just like, I'm having a bad day. Now you're going to be my victim. And my poor giant lab is like, what did I do? I have never seen like a kind of a vindictive horse, really, unless, people have made them to be that way. They're just these gentle giants for the most part, unless they're really afraid of something. Although I've definitely been whacked in the head by a horse just because they were looking around and they got startled, and it was my fault for not paying attention.
Yeah, I think that's really true. I mean, I have had, I guess one of the kind of less great parts about being an equine vet is certainly in this country, and I think it's the same in the US, it carries one of the highest risks of any profession you can be in terms of injury or accident. And I have had 2 sets of broken bones at work in 12 years. So, which was, again, I don't really think the horse's fault. It was sort of just one of those things in both occasions where it just happened and it wasn't really anyone's fault. It wasn't mine. It wasn't his. It was just one of those kind of things in life. But I ended up getting quite kind of smashed about in both occasions. And it does definitely make you think, well, maybe a desk job would be a bit better from time to time. But no, I really like it. I really love working outdoors, and that's definitely one part of the job that I would not want to be giving up.
It must be really rewarding, though, at times to help an animal that is not feeling good and helping them kind of get, well, obviously horses have to be on their feet most of the time anyways, but helping them kind of get back to doing what they love to do, because horses do love to work.
Yeah, I mean, I think that's one of the things that I really do like about being a vet. It's probably a little bit similar to medicine and lots of the kind of EMT work is quite often the clients, so we would say, we refer to the owners as clients and the horses as patients. Quite often the clients sometimes are very grateful, and I think sometimes people do just forget to say thank you, but that doesn't necessarily mean they aren't grateful for your work.
Yeah.
And that's one thing I try to bear in mind. People are quick to complain when there's a problem, I think, in all walks of life, whatever you do. Mm-hmm. And yet gratitude doesn't necessarily come quite so easily to a lot of people. But I do draw a lot of pleasure from seeing animals back out and about again, and to me, I think one of the things I enjoy about my job is when you solve a puzzle and then you work out how to deal with it. And yes. I think that's the kind of joy of diagnostics, whatever field you're in, really.
Right. Yeah.
And when we have complex medical cases, or you do something that you think, oh yeah, God, that was cool. And that, those are the sorts of things. Okay, so you spend quite a lot of your days doing really routine stuff that's maybe a little bit dull. But then when you have a cool case every now and again that gives you something to kind of get your teeth into, then those are the days that you look forward to at work.
So what would one of those cool cases look like in the equine world?
So, okay. So, I mean, I love a fire. Just trying to think of an example now. I love a fire brigade rescue. They're amongst my top favorites.
Fire brigade rescue. Okay.
Yeah. So I do. I've done quite a lot of animal rescue work over the years.
Okay.
Which it's not your average kind of clinical case, but they're often quite challenging and quite rewarding and satisfying if they go well. So road traffic accidents, lots of, horses are flight animals, as you said, Christine, and they love to get themselves in situations that are just quite difficult. So we've fished horses out of rivers and ditches and, stuck in, you've half jumped a stable door and you've got half your body on one side and half on the other, or you've tried to jump out of the lorry and you've made a right mess of it, or, whatever it happens to be. And I used to find those situations quite stressful because quite often the fire service are amazing at what they do, but haven't necessarily always been very well. They're not very used to horses, or they find them quite scary, or they haven't had a lot of animal rescue training. And often it will involve field anesthesia or field sedation. So we might do a general anesthetic in the field or whatever that may be. So those situations are all just quite interesting, and you have to think on your feet. You have to problem solve that.
Yeah.
You have to come up with ways of dealing with something that you might not have seen before quite quickly. And the other thing I found was that certainly sometimes you turn up and the fire brigade look at you and they expect you to lead. And that's not a situation that you find yourself in as a vet awfully often. And so I think, well, I know how to do my bit of the job, and you know how to do your bit, but now we need to kind of get this together and make a plan of how we're going to attack it. And those situations I find really rewarding. Just more in terms of clinical cases, had a very interesting cardiac case a couple of weeks ago. The heart problems are pretty rare in horses because they have enormous organs. So their compensatory capacity is absolutely massive. So they very, very rarely get liver failure or kidney failure or cardiac failure, because until they're about 70% decompensating, you wouldn't see any clinical signs of disease.
Really?
And it's pretty rare for them to get to that point. They normally die of something else first. But this was a horse that I'd been looking after for a long time, actually. And he was a very good, in fact, a dressage horse, actually, and a very good horse. And he'd had a cardiac murmur for quite a while, which we'd kind of been sitting on. And he'd had an ECG and an echocardiogram, and we do exercising ECGs as well. So we strap an ECG onto their chest, and then we ride them with that on to see what the heart does at exercise. And he'd had all of that done, and we had a diagnosis of he had a mitral valve murmur, as far as I remember off the top of my head.
Okay.
And very quickly, for unknown reasons, started to go into cardiac failure. And I'd only auscultated him maybe 2 weeks beforehand, and everything had been pretty steady. And suddenly he presented with a temperature, a heart rate of over 100, which at rest in a horse, their heart rate should be a maximum of about 40.
Really?
So, yeah, their resting heart rate's usually between 24 and 40.
24 for an animal that big? I don't know why that's...
Yes, they have a very low heart rate. Because their heart is massive. I mean, if you looked at their heart, it probably weighs... it might weigh 2 kilos. So what's that? About 5 pounds.
Yeah.
Their heart might weigh. It's huge. And yeah, so he was presenting with a pyrexia of unknown origin and this massive heart rate, and was all a bit confusing.
What is a fever in a horse? So what is a horse's normal temperature?
Up to about 38.5.
Okay.
I don't know. Do you work in Fahrenheit or centigrade?
So we work in 38.5 centigrade.
It's about 101-ish in Fahrenheit.
Yeah, so 101.3.
Yeah.
So, okay,
yeah.
so that's a fever in a human. So he's 100.4 and above is a fever in a human.
Okay, yeah. So they sit slightly higher, but yeah, he was sitting around probably like 100 and somewhere between 103 and 104 most of the time.
Oh.
And yeah, just started to decompensate, and very rapidly went into cardiac failure, and we lost him, unfortunately.
Oh.
But it was an interesting case because he basically had a localized abscess in the foot, which is really, really common. I'm sure you know, you probably had loads of those in your horses, and had developed a bacterial endocarditis secondarily. And that is so rare in horses. Like, I've never seen a case before. We see it in cows quite often, but we do not see it in horses. It's written up in textbooks, but the likelihood of you seeing it is really rare. And sadly, his caudate tendon ruptured and all everything. You know, he went into cardiac failure with pulmonary hypertension, and it was not good. So they made a decision to put him to sleep, which is always sad, but was the right decision in this case, I think.
That's just an amazing story, because also we had a guest on here talking about how she got a viral endocarditis, and then she ended up getting a heart transplant, and she was on ECMO, and so like bypass and all these things. And it's like, she's a good friend of mine, so I'd be like, wow, Alyssa, if you were a horse, they would have put you down by now. But that's a really big distinction between obviously veterinary medicine and human medicine, is that moment of, you know, when do we say enough is enough? Where do you guys kind of decide, you know, when is the end?
Yeah. So this is one of the things I find really interesting about my job. And it's one of the discussions I have a lot with friends who are either medical or perhaps even legal, because in Europe we have places in Switzerland where it is legal for people to be euthanized. So there's a clinic that you can go to. So end of life care and assisted dying is a hot topic in Europe at the moment. Mm-hmm. And it's one of the things I find really interesting. I think there's a growing movement. It's probably the same in the US, that people who feel that legalizing assisted dying would be a good move. One of the things I find is that getting particularly a family, and if you have various interested parties in any animal, be it a horse or a dog or whatever, getting people to agree about when the right time for an animal is difficult enough. And I think that one of the things I find really interesting about people who think that they would want to choose assisted dying for themselves is that you can make that decision while you are of sound mind and have capacity. Mm-hmm. But the pressure placed on someone else to make that decision when you are not of sound mind or body is extreme.
Right.
We see that day in, day out, that the failure or the difficulty for owners to make the decision on behalf of an animal is massive and hard. And my personal feeling is, although I think actually I joke frequently, and this is a joke, but I'm like, I'm stashing some stuff away for myself for when I'm old, But I think actually the reality of it is somebody has to give that injection, and somebody has to make the decision about when that's time. And making that call is very, very difficult. I think in animals, it sounds a bit cheesy to say it, but with experience, and over the years, particularly if you get to know your clients. So the lady with the cardiac case has been a client of mine for 8 years. I know her really well. She's kind of a friend. And so I know her and her horses really, really well. And so I can help her make a decision. And I would be quite blunt about when I thought the end was nigh, and we're at the point at which we cannot do any more to help you, or help him, should I say. And therefore, if you don't choose euthanasia, he's probably going to have an end or a death that is not as either as aesthetic or as kind. And I think when you put it to people that if you take this horse home and you choose to continue to allow him to live, you may well come down and find a dead horse in a stable, or a horse having a massive heart attack in a field, or whatever it may be. And that is distressing for people.
Yeah.
And I think the timing of when to make a decision is really difficult. I have left horses and other animals in situations where I felt that if I knew the client better, I would have pressed, because I felt that the animal was, I hesitate to use the word suffering, but I could have ended its pain at that point, but the client wasn't ready.
Yeah.
And that is a difficult balance to find sometimes, because they are the ones that have to make the decision, and you cannot force somebody. I mean, you can, but it involves the police, and in our case, the RSPCA. And I've never been down that road. I wouldn't want to.
Yeah.
But I think sometimes you maybe have to give it 12 hours for them to come to that conclusion themselves before you come back and they say, I'm ready now. And it's difficult, but I think I explain it to people in a way as being a privilege, that your animal doesn't have to suffer pain and it doesn't have to die in a way that a human would, because we don't have this privilege in human medicine.
Yeah.
And it's amazing how many people, when you say that to them, say, I would much rather that he or she was gone sooner while they still had a better quality of life, knowing that they don't have to suffer, and by extension, the family don't either.
Yeah.
Which is difficult ethically when you think about it, but it's the way it is.
You draw a lot of parallels to human medicine and the conversations that we as primary care providers have, especially when I'm recommending to a patient and their family, particularly family of the elderly, to think about hospice. Sometimes they're just really not ready. And I'm saying, I think, it's futile to be pursuing a lot of these treatments and interventions. And I'm really suggesting hospice, and they're just really not hearing me. It's not necessarily physician-assisted suicide or dying, but it's hospice is kind of like that next step. And a lot of people are just not listening to it. There are certain patients where, I've had better relationships with, where I can be much more blunt with them. Others, they just, are not listening, but it's at the same time, it's out of compassion and understanding the clinical picture a little bit better once you've been doing it for a little while. But I think we have a lot to learn from that, but it's also a very different world. It's interesting how there's parallels and then also not.
It's really interesting. And I think just what you're saying about being blunt, I think I have become more frank as I've got older.
Yes.
And in the early days, I would have moved heaven and earth to try and keep animals alive for as long as possible. And now I don't necessarily always think that's a good thing. And, I personally, and again, this is a very personal point of view, I am slightly opposed to some of the really extreme surgeries and operations that are carried out, particularly in dogs and cats. We don't really do them in horses, but mainly involving transplants and use of implant limbs and things like that. Because for me, and again, as I say, this is a very personal opinion, I don't think that in an animal that cannot consent, the level of pain that goes with those surgeries sometimes, and the level of complications that can be associated with them, for me, that is unjustified in some cases and some procedures. And again, I think there are different vets hold different opinions about those sorts of things. Maybe other people would disagree with me, but I think that sometimes in an animal that cannot provide its own consent, I think some procedures are done for the sake of the client, not for the sake of the animal. And I think that's an important distinction to make.
I think that's a very interesting point, because I think we see that in places like pediatrics or sometimes in geriatrics, where there's, again, like hospice or end of life care, where someone's being, decisions are being made for someone else.
Yeah.
Who is this care being done for? Is it really being done for the patient, or is it being done, for someone else's, internal struggle or the relationship that they have with that person, even though it's not really benefiting the intended recipient.
Yeah. And it's funny how one of the things that comes up time and again that I've talked about a little bit on my own podcast with, in terms of compassion fatigue, is that it's amazing how often we have people's own experiences or experiences of the medical profession or the death of a loved one as a human that impacts on their decision making about their animal. And I find that an incredibly interesting psychological thing as well in terms of humans. And I've spoken previously about the fact that clients will lean on you as a professional who is uninvolved in their life but is a listening ear. And I'm sure you probably find this all the time. I've been to people and said, how is Bertie today, or whatever it's called, and they say, oh, he's fine, but I've got cancer, or he's fine, or but my husband's having an affair, or oh, he's fine, but my kid's doing really badly in school, or whatever it happens to be. And suddenly you're like, oh God, here we go. And, but there's often so many other things that are wrapped up around the decisions they make about their animals. And one of the things that I know that you have a lot of black humor on your podcast, you probably appreciate this, but we talk about the Christmas clear out because you would not believe how many euthanasias we do before Christmas.
Really?
And yep. And subsequently, immediately post-Christmas, when people want to give them, quotes, one last Christmas, and then they decide they've had enough. And unbelievable. Like the amount of animals we put down in December is so many more than the rest of the year. So
explain this. So they put them down before Christmas because they're either expensive, I'm guessing, and then after Christmas because they had their Christmas and they opened their presents, the horses did, and now they're good to go. Is that the reasoning?
Yeah, I think sometimes with dogs, it's oh God, the family's coming. Everyone's coming around for Christmas.
Oh, we can't put Sparky down until Grandma sees him.
Either that or, oh my God, Grandma's coming and Sparky shits everywhere, or whatever it happens to be. We've been putting up with this for a while, but it's probably time. And the horses, they often, when it gets cold, they lose a bit of condition in wintertime.
Yeah.
Trekking out to see them at Christmas. Yeah. And I'm not criticizing that at all but it's just, it's definitely the way it happens.
And in my very dark humor, I am now imagining like the medical profession with Christmas clear out of Grandma before Christmas. And that's so a terrible, terrible joke. And I am not recommending that at all, but it's like, oh, she's getting a little up there. We had one less Christmas with her.
Yep.
That is a joke, and I am not recommending that at all. I'm just saying.
I know, but we do. And we sometimes have Friday clear out as well. So like if you have, this is more in small animal, but like, there would be times when people were like, it's 5 o'clock on Friday, you've got to kill it or refer it. Which again is like, it's just total humor. And obviously we do everything for our patients, blah, blah, blah. But yes, those are the kinds of times when you're absolutely shattered and you've got 20 inpatients and you're thinking, oh my God. So yes, it's definitely, there's a degree of, veterinary conversation exactly the same in the medical profession, which always is so funny. Like if you hear a bunch of vets in a restaurant talking about rectal exams, that's like totally normal.
Oh, yeah. Yeah.
So, yeah, it's pretty similar.
You need the humor.
I know you do. And my worst one is I used to do a lot of breeding work, which involves spending a lot of time with your arm up a mare's backside. Mm. And the worst one is then when you're in the supermarket aisle and you think, oh, I wash my hands, but I can smell myself. Why? And there's always the bit up the back of your triceps. There's always shit there. And it's like a really hard place to wash that you always miss because you can't see it. And it's that moment when you're like, oh, yes, definitely. I can smell myself. This is really nice.
So speaking of breeding horses, so my mom is a very eccentric lady, and she had a stallion, then she bred him for a little bit, and she decided in her world of being a loving mother, this is how she defined it, that, oh, it's your birthday, your 16th birthday, I'm going to take you out of school early and we're going to go see the stallion get collected. And
oh my God.
And you're laughing. Explain to people what a stallion getting collected looks like.
Okay. So a stallion getting collected now then. So there's one of two ways it can be done. He either can, when the stallion mounts a mare I'll describe it in like proper terms to begin with. When a stallion mounts a mare for intercourse and you collect them, you can either, quotes, collect it on while he's mounting a real mare, or they can be taught to mount a dummy.
Yeah, this was a
dummy. In which
case,
yeah, fine. So then basically what they do is they put their front legs onto a rubber and wooden horse. So he's essentially kind of mounting nothing. Mm-hmm. And at the point at which they're about to ejaculate, somebody runs in with what is called an artificial vagina.
Yep.
Which is essentially a giant condom with a warm water-based system around the outside of it, which has got a kind of sleeve around the outside to keep it warm, because stallion semen is very volatile and it will break down very quickly. So as he's then humping a fake wooden dummy, you dash underneath with a very hard hat on and lots of nerves to dive in there with your giant condom and stick it on his penis and then collect the semen that is produced as he is then ejaculating. We then take that and it's distilled down into lots of different straws, eventually for artificial insemination. So it's extended, it's purified, it's antibiotics are added, blah, blah, blah. And that can then be shipped out from wherever that stallion is to wherever you want it to go in the world. So that is the procedure. If you haven't seen it, it's a little bit alarming.
Oh, especially if you're 16 and then that story is not so scientifically retold at every dinner party from then on by your very endearing mother.
Yes, it's the point at which you then have to dash under the front legs of a rearing stallion that's mounting something that's not an actual horse. It's probably good it's not an actual horse because then you've got the back legs of another horse involved in this scenario.
It's like, what is up with this? Yeah.
Yeah. So I work mainly on the thoroughbreds. So in racing thoroughbreds, you're not allowed to use artificial insemination.
Really?
It must all be done by what they call natural cover, which is one bonk, one baby is what we call it in the UK. So basically it just means that it stops one stallion having too many progeny all over the world, which is not the same as show jumping, dressage, polo, etc., where they can use pretty much any kind of artificial breeding techniques. So they have now cloned polo ponies in Argentina.
Oh.
And that's been a successful breeding technique over there. But we, certainly in racing, it all has to be done with an actual visit, which means that we fly the horses around the world to go and actually meet one another. So that's a whole other industry in its own right of transporting horses.
They have one-upped Tinder, I am guessing.
They have one-upped Tinder.
Yeah.
It's not a quick swipe on a Friday night.
No.
There's lots of preparation involved. So yes, so they transport the stallions between the northern and southern hemispheres. So they will usually stand in either America, Ireland, France, or Great Britain. And then in the winter time, they might go to New Zealand, Australia, South Africa, maybe South America sometimes. So they're only breeding when the weather is warm, wherever you are. So currently it is just the beginning of the breeding season in the UK and Europe and where you guys are. And once it comes to kind of August, September, they start the breeding season in Australia then. So there you go.
Yeah.
I can imagine that was quite an eye-opening experience for you, Christine. I do not envy you.
And yet I still pursued a career in medicine. I think my sister, who is in more of the business marketing side, would have probably passed out. But I was like, wow, that little vet that is running under there, that is a ballsy little man, no pun intended.
Well, at least it wasn't a dog. So,
yes. I don't even want to know.
Yes. Let's just say it's done manually.
Oh, yeah. Okay.
So, yes, that one, not my cup of tea personally. But anyway, there we go. There's so many things that most people in their life will never have even thought about.
That's not how fertility specialists do it with humans.
Really? Oh, there's a niche there somewhere, I'm sure.
You know what? I won't speak to that. I'm not a fertility specialist, so I won't know.
Yeah. So you can't really give the dog a pot and tell them to go to the toilet. So
yeah. There's some magazines in there. So any good heartwarming horse stories of cases that went really well?
Oh yeah, loads. So it's always good when we have, I'm just trying to think of some others. Yeah, I mean, I guess one of the commonest injuries we deal with, particularly on the racetrack, is fractures. So we deal with a lot of stress fractures, so same as in human athletes as well. And often they'll be we just pin them standing. So we do them under standing local anaesthetic for horses because general anaesthesia is inherently risky if you're a horse. The quoted death rate under general anaesthesia for horses is 1 in 100, which is not true these days. But the last study that was done on this was in the early 2000s. So
is it because their heart rate is so slow or because they have to stay? I know horses have to sleep standing up. Is it?
Yeah. So there's a few main issues with anesthesia. The main one is particularly you have to put them on their backs. The weight of their organs is so massive that it reduces their venous return massively.
Like pregnant ladies.
So they tend to, yes, very similar. So they tend to become reasonably hypoxic and a bit hypercapnic, and their arterial gases tend to get a bit funky. So they generally are quite poor for long anesthetics. And then we use ketamine anesthesia in horses still, which is the best, in combination with lots of other things. But still, they can have some quite interesting recoveries. And recovering a 500 kilogram animal, which is generally a flight animal and likes to try and get up as quickly as it can and run around, just means that sometimes they have accidents in recovery. So touch wood, I did a lot of anesthesia for a while. I spent a year-ish working as an anaesthetist, and I had one horse in that time that fractured a leg in recovery, which was quite an unpleasant experience.
Aww.
But mainly they just can do whatever. I mean, the clinic I used to work at, they had 1,000 anesthetics without a death. So, the rates are much better than quoted, but still it's like so much higher than what would be acceptable in human medicine, obviously. Yeah. So we try and do things understanding anesthesia increasingly with just sedation. So horses sedate very well. So we do a lot of things understanding sedative, and most of the kind of head surgeries we do, or dental surgery or back surgery, lots of breeding, reproductive surgeries are all done standing. And now fractures would be routine, uncomplicated fractures would be probably routinely fixed standing by a lot of clinics. It's surgeon preference, but quite a lot of them will now do standing surgery. So obviously when they then rehab and come back to the track, when you've brought one of those back, that's always a good feeling when they ship out and they don't look great, but they come back and they can keep going and off you go again. Those are always good. And my favorite heartwarming is just difficult foalings with a successful baby outcome is always really good, because they're just really cute.
Yes,
to be honest.
They are. They're so sweet.
And foalings are, you have about 20 minutes when you return to foaling to have a good chance of a live foal. So you have to be, because a foaling in a mare is so incredibly explosive and it happens incredibly quickly. If there's a problem, which is quite rare, the things tend to go badly wrong quite quickly. So if you end up foaling something for a long time, you will usually end up with a dead foal, and often you'll end up with complications from the mare as well. So a successful foaling outcome of a difficult one is always really, really, really good.
So usual labor process for a mare, you said, is 20 minutes?
Yep.
Wow.
It's very fast. They will have a kind of, so we have 3 stages of labor. Their stage 1 can kind of rumble for a while. They also have the capacity to switch off their labor process if they get disturbed. So
that makes sense with their flight animals.
Yeah, exactly. So there was a really interesting study from one of the universities, it was in North America actually, a few years ago, where they had a bunch of brood mares and the students go round during the night. So they would do nightly checks. So the students are out there every 2 hours, they put the lights on, they make noise, and it's really, most mares will foal at nighttime. So the majority of foals will be born between kind of 7 p.m. and 7 a.m. And this hospital had a weird stat where nearly all their foals were being born during the day. And they realised after a while it was because the mares were being poked about by the students so often at night time that they were like, God damn it, leave me alone. I want to give birth in peace. And so, of course, they were then flipping things round, and those foals were all being born in daylight hours, which is great for everyone involved because A, the students get to see them, and B, it's much more sociable for everybody. But they definitely have this amazing capacity to just switch off their kind of early birthing process if they want to.
Wow.
And then, when they get set into proper labor, they will get down and they push, and it's incredibly quick. It's so explosive that it's very rare that they have a problem. They don't get fetal oversize in the way that cows do.
And they fetal oversized, you mean like a large foal? Large
calf for a small cow is very common in cows. Okay. So you'll often get what we call hip lock. So they get stuck at the hips when they're coming out, because they come out, if you imagine a foal or a calf, they come out front feet plus head first. So they kind of, like you would be doing a dive off a diving board is the only way I can describe it. Yep. So they arc out with their arms, quote, and their head to begin with, and then their body and then their legs will follow behind, stretched out like a diver. Mm-hmm. So if they've got a leg back or a head back or something, those can be corrected quite easily because we can get both our hands in and you can kind of manipulate them around. And it's only if you start getting, significant problems one way or another that things don't go to plan. So yeah, a foaling they generally happen as a problem at about 4:00 in the morning. So you get that call when you're like, I don't know where I am. And then you have to get in the car and you still wear your pajamas on or whatever. And you have to get there really, really quickly. And I've driven like a crazy person at some ungodly hours of the day and night. And most of the time with inexperienced owners, you arrive and there's a healthy foal on the ground and they say, oh yeah, it popped out just after I phoned you. And you're like, yeah, okay, cool. That's great. But then other people who are really experienced at foaling, you think, oh shit, if they can't get it out, this is a problem.
Right.
So then you start prepping for big deals.
Do horses get like nuchal cords where the cord's wrapped around the foal's neck, or the placenta is in the way? Like placenta previa, or that we get in humans, or is it just not a thing that horses have?
So they have a different placental setup to humans, as far as I know. We have something called a red bag delivery, which is sort of similar to a placenta previa, but the foal is basically delivered with this kind of red exterior to the sac. And, good stockmen would know that you immediately need to slash that and get the foal out of it, because otherwise they will become rapidly hypoxic. Mm-hmm. But yes, they can do. I mean, often, because the foals have got such long limbs, they will often they should naturally sort of break out of their sac as they come out anyway, in which case they tend to be able to breathe okay. And you have to kind of bear in mind that humans have a 9-month gestation period. Horses have an 11-month gestation period, but they're a lot bigger when they're born. And they're also a lot more developed when they're born. So they would expect to get up, feed, run around, and be ready to move with a herd within about 1 to 2 hours normally. So a healthy foal is kind of, you're on the ground, I'm up, I'm ready to go, life is on. They're not like a baby in the sense that
they're not useless like human babies. Jeez.
Indeed, yeah. Dogs and cats completely useless when they're born. They just are blind and squeak and do nothing. They look like little slugs. But foals are just like, I'm ready formed, I'm fully formed, I'm ready to go, let me at life. And they will get up and they will go. And that's how they're born. So it all just happens really, really fast, basically. So they seem to be quite well adapted, that a lot of the problems we get in humans don't seem to be too much of a problem for them, or they can kind of self-correct, or they somehow seem to get through them okay. It's only if they have mainly malpositionings that are a problem. So if they're coming the wrong way around, it's a problem. If they're coming upside down, that's a big problem. Those things have to be manually corrected.
Do you ever do a cesarean on a horse?
Yeah, we do.
Oh, yeah. Okay.
The big hospitals, so in Newmarket, which is near where I live, where they do a lot of breeding work, they would do those quite routinely. Or the other thing we will do is what we call an assisted delivery, which is basically where you would anaesthetize the mare, and it sounds kind of a bit awful to say it, but you hang their back legs so that their head is downwards, so the foal will drop back down into the abdomen, which allows you to then manipulate its position internally, and a bit like asking a woman to raise her legs so that you can manipulate a delivery. And then once you've kind of got them in the right place inside, then you can safely deliver them after that. And that will work quite often if you've got a malpositioning that is not too bad, but just needs a little bit more help. But it's absolutely exhausting work. I think even, there's not many things as a girl I find that a man is better at me at. Like, I'm a massive feminist and I don't really believe in that. But it's physically so demanding.
But hanging a pregnant mare upside down, I can imagine that would be very...
Well, no, we hang them from a winch, but just the actual foaling is, having your arms inside something and trying to manipulate something at shoulder height that's quite heavy it's really tough. And even the boys find it very tough. We'll often work in shifts, and, you'll go for kind of 5 or 10 minutes and then let someone else have a go, because it's just physically really exhausting.
Wow. That's awesome. I mean, these are just great stories. It's just so fascinating to hear about something that is so closely related, but also worlds apart from what I do. Like, I know all the terms, but they're totally different. Like a heart rate of 24, that's weird. It's a big animal.
I know. Well, I listened to a friend asked me to listen to their heart recently, and I put my stethoscope on, and I was like, "Oh my God, it's really fast!" And then
Are
I was
you
like,
dying?
"No, that's probably normal. It's fine. I think you're fine." So, no, you don't have a murmur.
Your heart is tiny.
Yeah, exactly. And the horses' hearts are so loud when you listen to them as well, because they just beat really like really strongly. And so then, yeah, it's just really funny when you go and listen to something else afterwards. But no, it's good. It's good. No, it's been a great career. And I was very lucky, actually. I haven't even told you any of my craziest stories yet, but some of my best ones come from the very first job I had, which was I went to work overseas for a charity, and I turned up to this island in the South Pacific, which was an amazing place. If you imagine like your best tropical paradise, that's it.
Mm-hmm.
And I worked for a clinic there, and I had thought that I was going to be supervised by somebody, but when I arrived, it turned out that I was actually the only vet there for a little while.
Oh.
And there was no other vets for 3,000 miles.
That's fun.
And then another girl turned up from London who was also newly graduated, and was basically the blind leading the blind. Neither of us really knew anything about clinical practice because we'd just come out of college, and we had all this theoretical knowledge but no like practical experience at all.
Yeah.
And they were like, yeah, just crack on, So we were like, okay. Surgery, well, we'll have a go, And it was kind of, if you don't do it, no one else will do it, because there's no one else to do it, really.
Yeah.
And our X-ray machine was so old. It used to spontaneously self-expose. And we then had to ship the plates on the back of our motorbike to the local hospital, which was only open between 10 a.m. and 4 p.m, and pay the radiologists to develop our X-rays for us in their machine. So we used to kind of tool off with the X-ray plates under one arm on the motorbike, like up the hill to the hospital, which was just crazy. And then if it wasn't right, or it was overexposed, or actually the machine had just self-exposed and it was a picture of, someone's foot or whatever.
Oh, no.
You'd be like, oh, God, I have to go and take another one. So drove back down and up again.
Oh, that's crazy.
So, yeah, it was I had 6 months there, which was, just the best experience of my life, without a shadow of a doubt, and was certainly the making of my career. But there was times when I learned a lot of surgical procedures out of a textbook, which is, I guess, what people would have done in the old days, really.
Yeah.
And just looking at diagrams and anatomical drawings and, trying to kind of fish your way through something that doesn't really look like the textbook. I did my first amputation on a road traffic accident dog, and amputating a hind limb when something is really quite traumatized and looks nothing like a neat anatomical drawing in a textbook was really stressful and difficult. But, we learned really good surgical skills in that scenario. And I guess it's a little bit like being a kind of, charity medic. If you're working overseas or whatever, you just learn to deal with very limited resources and very limited supplies of drugs, and you just do what you can with what you've got, really.
Yeah.
But yeah, the girl I was with and I we're quite into sailing, and on Saturdays we used to go to the sailing club, and we raced around these little islands in the Pacific, and people learned after a while that on Saturdays we would be at the sailing club, so they used to turn up with their dogs and just be like, oh, he needs help, and you'd be like, okay, I got a stitch kit in the car. Like, okay, we'll just do a quick stitch up, like on the balcony of the sailing club or whatever it was, and it's just a crazy time, but really fun.
Wow. I think when it comes to procedures like that are so significant, and I have never done surgery, but I've certainly sutured things, and you're just learning how to do it. And you're like, I'm not great at this, and I'm like kind of terrified inside, but I'm just going to pretend that I'm good at this to the patient, and inside you're kind of freaking out, but that's how you learn. Like, that's how you get good at something, is being really inexperienced the first couple times you're doing it, and then you just keep doing it. And that's how you build confidence, is just working through that fear and that lack of familiarity. You just got to get through it.
Definitely. And I think it's something that it's sort of it conditions your own personality to a degree,
definitely.
Because
definitely.
I take quite a lot of students out on the road with me now, and quite a lot of them are very nervous about doing procedures. They've been told a lot about litigation, and I think a lot of them are quite anxious as well, because they're scared that they are going to have issues with things that they can't control. And the one thing about that situation was that I didn't really have a choice, that you just had to get on with things. And we had things that didn't go well, don't get me wrong. I had one case in particular that I look back on, and I won't go into the details, but I shudder now still. And I think, God, that was bad, but that was one case out of thousands of animals that we looked after in that time. And, I think when you're in a situation where you either have to sink or swim, if you learn how to condition yourself to swim under pressure, it serves you quite well in life, I think, personally. But it depends on the kind of person that you are, because some people, that is just too stressful, so stressful that it becomes a really negative experience for them overall and doesn't allow them to flourish.
Right.
And I think having periods of controlled lack of stress was important for us, because the times when things were difficult was very difficult. And actually, I said, my husband and I were talking about this a few weeks ago, and repeated stress like that over a period of time can be really unhealthy and actually leads you to become bad at your job.
Yeah.
But having periods of exposure to things that are uncomfortable, which if you then succeed, totally allows you to grow, as in my case, a surgeon in that situation. But I think whatever you're doing clinically is important that you stretch yourself from time to time.
I always say it's amazing what you can do when quitting isn't an option. And then you get this confidence of, you know what, it's okay to be wrong sometimes. I mean, sometimes you can be really, really wrong. And I was listening to your podcast about the surgeon, and she says you can't be afraid of failure. There's little failures and there's big failures. And it was so true that, sometimes you're going to fail at things, but you have to, what do you do with that failure? And it's not always going to fail. But sometimes you just don't have a choice. There's no one else to ask. Someone's might be bleeding in front of you. You need to be the one to suture up whatever this wound is. And you're not the best person to do this, but you're the only person to do this. So what? You got to do it. And now you learned, and now you know how you respond in these situations, and just staying calm and knowing that you can find the answer, even though you didn't have it 10 minutes ago, having that confidence in yourself, it totally changes who you are as a person, or at least it does for me. I mean, other people would go, nope, I don't want to do this job. I hate this job.
Yeah, no, definitely. But I think also the other thing I've sort of learned over time is that it's easy for other people with hindsight to criticize your decision making in situations like that.
Yeah.
And I've certainly had situations at work where maybe I haven't made the best decision, either clinically or emotionally or in terms of managing a client or whatever it happens to be. But at the same time, my mom has this thing of, you can't have regrets because you made a decision and you thought that was the best decision that you made at the time.
Right.
And whatever that happens to be, you did what you thought was best. And that was one thing I really took away from that job, was that done is better than perfect. And I would say that I'm not a great planner in life, and my own podcast was a kind of example of that at the beginning. I just kind of leapt in and got going with it.
Oh, mine too.
Without really any idea about what I was doing. And then I learned as I went along. And that's the kind of person that I am, is that I tend to be a diver in, and then I will troubleshoot as I go. And I think sometimes that has to be a little bit managed in the veterinary profession, because actually you don't want to become reckless. And I don't think I ever have been reckless, because I'm too scared to be reckless, to be quite honest. But at the same time, I'm someone who is happy to take plunges with things and think, oh, it'll be fine. I'll just work this out. I'll be all right. And I think that has, to a decent degree, served me quite well at work. And, I think particularly those sorts of emergency experiences, and I know that you've got a lot of experience in emergency work and stuff, those are the ones where you have to make decisions quickly, and having the capacity to be a authoritative and confident decision maker is not something that comes easily to everybody, and it didn't used to come easily to me. But now I just think I have to make a decision fast, and I just trust my own gut so much more than I ever used to. Because partly it's through experience, isn't it? You learn what's not cool to do in a certain situation. But sometimes you just think, I think this is right, and I'm going to go for it, and I'm going to do it. And maybe it doesn't turn out to be, but at the same time, most of the time it does, doesn't it?
Yeah. My boyfriend and I would go to trivia, and sometimes, if we didn't know the answer, there would be certain situations where no, it's this. And he was like, okay, sure, you're so confident about it. And I'm like, sometimes I'm very good at being very confidently wrong. And that's not a great thing.
Me too.
But very confidently wrong sometimes. And, usually when I'm like, oh, I think it's this or I think it's that, and I'm like a little bit right, I'm like, no, because that comes from work. Like sometimes, even if you're not right and you like have backup plans, you just have to be very confident. And I'm not saying it's good to be false and be overconfident, but sometimes you just have to pick a path and go with it and understand that you may have to, we say adjust fire in the military, but you adjust your course later on once you get more information. But given the information you have to dive into it, because being wishy-washy and going between 7 different things isn't going to get you more information. So just getting out of that situation with one plan of attack is what you need to do. So sometimes I'm confidently wrong. Sometimes I'm very confidently right. A lot of times I'm very confidently right.
It's funny because actually I'm exactly the same. And it's one of the things that I think I have developed at work, because horse owners are majority women, and there's a real thing about kind of male equine vets that they come out of college and they always just seem to be really confident. And I think a lot of the girls are probably clinically a little bit more skilled with a little bit more knowledge. I'm making like sweeping generalizations here because but we so often see it that these guys they're often very good looking, they're often really smooth, and they just seem to fly through, and all these women owners love them because they just have all the chat and whatever. And I think particularly I hear this a lot from students, that girls are often, they say to me, I'm really a bit nervous or whatever. And now I think part of that is that to make owners feel confident with your own skills, you have to project a degree of confidence in yourself.
Yeah.
And when I was younger, I definitely used to say to people, well, it could be this or it could be that. Okay, well, if I do these diagnostics, I'll be able to differentiate between these things.
Right.
And then we have this treatment plan and this treatment plan, and you have option A, B, and C, so you can do this, and this is how much this will cost. And I think that was all right. It was all correct. But I think sometimes if you offer people too many options, it makes you look indecisive.
Right.
So now I've really learned over the years to try and boil things down to being very simple. So I give people a maximum, I try and boil things down to like a maximum of 3 things. And if it's really complicated, then clearly it has to be more complicated than that. But I think just the keep it simple, stupid theory really works for me, mainly because I'm quite a simple person and I quite like things to be broken down very simply. And so that's what I try and do. And I think if you confidently say to people, it could be X, Y, or Z, I think it's X, this is the path we're going to take to begin with diagnostically, and this is the reason why. And if that doesn't work, we can go down the Y or Z route. There you go. And I think that is something that I've kind of learned communicatively seems to make people more receptive, because I genuinely think that owners, and in your case patients, if they're given too much information, they just switch off and they don't listen to you.
Right.
And people don't take on board what you're saying. So it pays to say a little bit less, or to say it very clearly, than it does to give them a half an hour lecture about possible diagnoses and possible treatment plans.
Yeah. Yeah, I've learned.
Do you find that as well?
Yes, definitely. Because, obviously I overanalyze everything, and I'm like, oh, what are the 7 million differentials for this one thing? And you realize me understanding every single little thing it could be actually comes off as me sounding very unsure of myself, even though I'm being very thorough. So yes. I have found that I'll say exactly what you said. Well, these are the things that it could be. I don't know yet. Just means we need more information. This is my plan to get more information. The most likely thing is this. If the tests don't tell me what I think they should say, or, if this treatment plan doesn't work, I have other plans. Follow up, you're coming back in a week and we'll discuss those at that time.
Yeah, of course.
So I don't say what my other plans are, those 17 other differentials of weird tropical diseases that you may have picked up. Like, I don't go down that route because they don't need to know that. But, and it's not to withhold information because I think they're stupid, but I have found that people just think that I seem like I don't know what I'm doing, even though I know what I'm doing. It's just, it makes me look insecure or unsure of myself, even though that's part of the process. Not everyone understands our diagnostic process, that it's okay to not know right away. They want answers immediately, which is understandable. So kind of giving them the I don't know answer, but most likely this with a plan is like oftentimes a really good answer if you say it confidently.
Yeah, definitely. And I think that's, confidence is definitely something that comes with age as well.
Yeah. I think you're out to prove your knowledge base to a lot of people, but it really can be tough, but also can be really helpful as far as learning who you are as a person and how to navigate life in general. I think it's kind of changed my personality for the better.
Yeah. But I think also staying humble along with that.
Yeah.
And, you've just mentioned about seeking collaboration with other people. That is one of my favorite things about the job. The second I have a chance to ring up a specialist and be like, give me more knowledge.
Yeah. That's my favorite part of this podcast, too, is like I get to learn all these crazy facts from people that I would never talk to usually. And you just expand your knowledge base of the world. And it's just so cool.
Yeah, definitely. Definitely. And I would be someone that I'm always like thirsting for what's new.
Yeah.
And like, okay, so give me more. And if I don't think I know something enough, I would definitely be the first person to pick up the phone to someone else. And I'm not scared to say to clients, I don't know. I think feeding bullshit is worse than anything else.
Right.
And actually, I think being afraid to say I don't know is a dangerous thing for any medical or veterinary practitioner.
Right.
Because you're never going to know everything. So I think sometimes I will say either, I don't know, but I know someone who does, and I will find out. Or I don't know yet, but when I've got the results of X, Y, and Z tests, then yes, I'll be able to give you some more information.
Yeah. And that was one of the hardest things to learn coming out of school is how to say that confidently and how to say that and say that appropriately to not freak people out. Yeah, it's okay to not know. We just need more information here. And then they're like, okay, yeah, whatever. Not feel like you're letting people down.
My last boss was great at that. He's really, really amazing vet. He's only a few years older than me, but he's extremely experienced. And it was him I heard on several occasions saying, well, this is weird. This is not a usual case. I don't know the answer to this. And he's so confident at what he does know, and he knows a lot, that the second he says, I don't know, someone says, oh, well, that must be a really odd case. And I thought, actually, that's a great position to be in, that you're so respected that when you say, I don't know, everyone immediately thinks, ooh, this must be really rare. And I thought, actually, that's where you want to aim to be, is that you can do the basic stuff so well that people have great confidence in you.
Yeah.
When you need help or you don't know, it doesn't make you look like you don't know what you're doing, and that's a tough place to get to, but when you get there, that's a great place to be.
I also have found that people respond very well to when you go, not saying I don't know, but oh, this is a very unusual presentation. They love to
that
be
one.
Unique. They're very happy when you don't know because they're special and it's a very unique thing. And you're like, they're like, oh, well, they say this is a very difficult case, so that's fine. This will take a little while. And you're like, okay, that's great.
Yeah,
I know. Oftentimes it is, so that's fine.
Yeah, sure.
So I have loved hearing your stories, but tell us more about your podcast.
Oh, thank you, Christine. Yeah, so my podcast is called Smashing the Ceiling. And thank you for listening to the episode that you've mentioned is one with somebody called Jamie Coleman, which listeners of this podcast may also be interested to hear.
Oh,
it's a medical-based, that's a medical-based interview. She's a trauma surgeon in Denver. The other one that actually I think you would also be interested in was one with a lady called Barbara Natterson Horowitz, who is a medical doctor at UCLA. She's a professor at UCLA, currently at Harvard, actually. And she is someone who she's a cardiologist, but has investigated the links between human and animal medicine quite significantly. She's very cool. But anyway, yes, that podcast came about because I was having a wobble about my own career. And I'd wanted to be a vet forever and ever and ever. And I had this sort of list of things, and I was like, oh, I'd love to be a journalist, or I'd love to be a travel writer, or I'd love to be a winemaker or whatever. And because I love wine. And I just was like, how do you get into these jobs? Like, how do you learn how to be these things because they just seemed really difficult. And the short version of the long story is that I decided not to quit veterinary in the end. And I have tweaked my career, I guess you would call it. So I now have kind of 3 different jobs that I run alongside one another. But what I did do then was start talking to other women about how they got into unusual and interesting careers. And what I wanted to do was make a podcast, which is a series of interviews with women who do things a little bit differently. So the kind of tagline of the podcast is inspiring women with interesting careers. So it's kind of anyone who does something weird or quirky or unusual, or if they've had a bit of an unlikely career path, and they basically talk to me about what they've done in their career, how they got there. So we talk a lot about like how their failures have contributed to what they've done, or how the people who've mentored them have helped them in their career, or what motivates them at work, and all those kind of things. So it's really wide ranging. Some women have been the first to do what they've done. Some of them have just taken a kind of wiggly career road, but all of them have sort of walked the road less traveled a little bit. And that is the USP of the podcast. So yeah, you can find us on iTunes if you just search for Smashing the Ceiling or wherever else you find your podcasts. And if anyone would like to give me any guest suggestions, I'm always keen to speak to new people. I've recently had a storm chaser who was very cool. And this week's one was with a clinical psychologist who specializes in people with psychosis, which was also really interesting. So it's quite varied. There's some kind of wild and wackies and some which are just a bit cool. So yeah, that's the kind of plug for my podcast. Thanks, Christine.
Yeah, of course. It was so interesting. I was listening to it on the way to doing a call this morning, and I was listening just the way that she was talking about balancing life and this amazing career, but also having kids, which of course, if you're anyone that works in medicine and you're like, I want to go to all these schools and do all this stuff, and how do you like have kids and do that? And I don't have kids, but that's always something that's just in the back of your mind. And she talked about it, and it was just super motivating, and how she does what she does. And I was just like all amped up, and I was like, yeah, this is great. So I think anyone that, obviously I'm definitely a feminist, and anyone that listens to this podcast would definitely love listening to all the different stories on your podcast. So check Smashing the Ceiling out on iTunes.
Yeah.
So
thank you.
Yeah. So thank you so much for taking the time on your Sunday to talk to me.
Oh my gosh, no problem at all. Well, it's been such a pleasure. I've had such a joy listening, like chatting with you, and I love listening to your podcast as well. So yeah, it's you're doing great work. I really, really enjoy it.
Thank you. You too. All right. Thank you so much to Naomi again for being on. And don't forget about our raffle for Dr. Howard's book that's ending this Saturday, April 13th. Make sure you are sending me screenshots that you are sharing it so you get entered. And if you want to reach out to me on social media, it's Antidote Stories in Medicine Podcast on Facebook. There's that great Facebook group. Also, there is Instagram, Antidotes Podcast. Twitter is Antidotes Pod. I'm Christine, the NP. And of course, you can always send me an email at antidotespodcast@gmail.com. And as always, thank you so much to Peter Hopkins, the wonderful musician, for our custom music. Check him out on YouTube, on Instagram, and his website, petesingsthings.com. And keep sending me those messages. I love hearing from everyone, and I love hearing your stories. That's how I get in touch with a lot of my guests now these days. So reach out to me if you've got a cool story. I want to hear it. I'd love to have you on. Have a great week. I will see you all next time. Bye.